Hi, Miss Nikki here. Welcome to Chapter 18, Part 2. We're going to focus on hemostasis in this lecture. We're going to talk about leukocytes, and we're going to talk about blood groups. So this first slide here is showing you the 3 steps of stopping bleeding. We're going to talk about vascular spasm, we're going to talk about platelets and platelet plug formation, and we're going to talk about the coagulation phase. And this is a little bit more complex than what it looks like right now, but we're going to walk through all these stages. In part 1, we were talking about erythrocytes. So now we're talking about blood groups and the fact that different surface antigens give us different blood groups. So on the surface of the red blood cell, you're going to have antigens. So here's a red blood cell, and on the surface, you're going to have tags. We call these tags antigens. They're going to create some sort of response, right? So if you're type A blood, you have antigens for A. If you're type B blood, you have antigens for B. If you're AB, you're secreting both or expressing both. And if you're type O, you have neither. So you'll often hear me talk about these being naked. They don't have any antigens or proteins sticking on the surface of the erythrocytes. A person's antigen status is determined by their antibody status as well. So antibodies react with antigens. So if I have an antigen here, this is type A, I have an A antigen, that person is going to make B antibodies. And if you think about it, that antibodies are made to bind to something that's not supposed to be there, right? So if you have A blood, these A antigens are known as self-antigens. You recognize them, they belong to me. So anything that has a B antigen is going to be foreign. So those antibodies will attach to the B and tag them for removal. So a person does not have antibodies for their own proteins. They only have antibodies to those that are foreign to them. So blood type A has B antibodies, blood type B has A antibodies, AB doesn't have any. They don't have any antibodies, and O makes both A and B. I think the visual picture is a little bit better. Here's type A, they're making antigen A. Here's type B, they're making antigen B. If you're AB, you make both. And if you're O, you make nothing. There's no tags or no antigen AB tags on your red blood cells. What's floating in your plasma? Well, you're going to make antibodies against B, right? Against A. Neither, because A is okay, A is yours, and B is yours. Those look normal to your immune system. They're like, check, those are ours, we're good. So you don't make any antibodies. And then if you're O blood type, you have 0 antigens, neither surface A or B antigens, and so you're going to make antibodies against both A and B. So if you're type O, and I give you type A blood, the A antibodies are going to bind to that red blood cell and target it for removal. There's also another factor called Rh factor. The antigen is called D. So on erythrocytes, you can either have the presence or absence of this D antigen. And so here they kind of show it in this block form, right? So they're saying if you're positive, you make, right, antigen D. If you're Rh negative, nothing. So you'll see, we'll say somebody is AB positive. So if I saw that red blood cell, it would have A tags, it would have B tags, or antigens, right? A antigens, B antigens, and then would also have D antigens. So if you're AB positive, you're expressing all 3 antigens. What happens if you're O negative? Your red blood cell, you have no A antigens, you have no B antigens, you have no, the Rh says here, says that you have no antigen D. So Blood type O negative, you do not have any of those antigens expressed on the surface of your red blood cell. Most people ask these questions, right? So what type of blood do I have? And then who can I donate to and who can I receive blood from? So if you receive an incompatible transfusion, so your blood type A positive, right? And I give you blood that's B positive. What we call that is agglutination, when they're the incompatible blood type and the antibodies start reacting. So remember, if you're blood type A, you have A tags, A antigens, and you're making antibodies against B. So what happens if I give you B blood? All of these antibodies start sticking to the B red blood cell, and they all start clumping together. So agglutination, if you want to think of this as clumping, that's fine. I wouldn't use the word clotting because that's something different that we're going to talk about. So clumping is fine. So the recipient, the person receiving the blood, their antibodies are going to bind to the erythrocytes that they were given, the transfused ones, and cause them all to clump together. Imagine, thick blood we talked about isn't good for you. So imagine now that you've got a whole clump of red blood cells with antibodies and they're all clumping together, that could block blood vessels, prevent normal circulation, right? Cause blood pressure issues. Eventually it's going to cause hemolysis. So you're going to see a rupture of the erythrocytes. This can also cause organ damage. If this clumping happens to get into an organ blood vessel, it can cause damage to the cells that make up that organ. So think of like kidneys, that would be kind of bad. If you want to look through this list here, they'll talk about O negative being kind of the universal blood. We can give it to everyone. So all blood types can get O. They can only receive blood from other O negative people. And then you'll hear them talk about AB positive being the universal recipient. AB positive, you can give them A blood, you can give them B blood, you can give them AB blood, you can give them O blood. All of it works. Their immune system recognizes all of it, or in the case of O, it doesn't see because there's no tags on it. But they can only donate to other AB people. So AB positive can receive all blood types. O negative can give to all blood types. Here they're showing you a process of the agglutination. They're showing you that the red blood cells that were being donated are clumping together, and you can see if they end up in a narrowing of a blood vessel, that could cause a problem. We haven't talked about capillaries yet, but we do have some really small blood vessels where only 1 or 2 red blood cells can squeeze through. So any sort of clumping could cause severe damage. On this slide, they're showing you what agglutination would look like if you were doing it in a blood test. So this is what you would see in lab on the far right-hand side, right? If you are in lab and you do a blood test, this is no agglutination. I'm just going to abbreviate. And this is clumping, or yes, there is agglutination. We use this to do blood typing. Basically, you're going to see in lab that we have a tray that has 3 spots. One spot's going to be for RH, one's going to be for A, one's going to be for B, and those are for antibodies. So I'm going to put a drop of blood here, drop of blood here, drop of blood here, and then I'm going to put on anti-RH or anti-D. I'm going to put on antibodies for A. I'm going to put on antibodies, draw my little antibody, for B. So the only way you see clumping is if the antibody found its target on the red blood cell. So here's the donor. Donor type is A, right? We give this blood. The donor is donating to the recipient that has blood type A. So they're the same. We did a correct match, right? They had A, we gave them A. remember, if you're A blood type, you're making antibodies against B. B would be foreign to you. So because there's no B present, there's no agglutination, nothing clumps, sticks together, no agglutination. If the donor is A, but the recipient is B, they have B blood, what's going to happen? The recipient has antibodies against A, right? Remember, if you're B blood, you're going to have the kind of spiky B antigens, and you're going to make antibodies against A. So the anti-A antibodies are going to stick to these A antigens on the blood you were just donated, and it's going to cause this clumping or agglutination. This becomes a problem with blood types. A lot of us don't know our blood types, and that's fine. But it becomes a problem if you're pregnant and mom is negative. So if mom is Rh negative and her baby is Rh positive, so her baby received an allele from dad or a chromosome from dad that made them positive, then you have to worry. Because remember, mom would have a red blood cell with no antigen against D, right? So the baby has positive, so the baby is going to have antigen D expressed. So what happens when the mom's immune system sees this antigen D? It's not normal, right? To her, it's not normal. She doesn't have any. Mom has antibodies against D. They could cross the placenta and start destroying the fetal red blood cells, right? So hemolytic disease of a newborn. So pregnant women, they're tested, and if they're Rh negative, they're given synthetic immunoglobulins, basically to try to block this immune system from recognizing and destroying red blood cells. So it can kind of bind up these anti-D antibodies. Leukocytes, we're going to kind of move on and talk about the different types of leukocytes. And basically, we're talking about white blood cells, right? That was the term we kind of used before we knew the anatomy term leukocyte. They're going to defend against pathogens. These do have a nucleus. They do have organelles. They are going to be moving around in the blood. We do have some in tissues that we'll talk about in a little bit. And they're kind of laying the groundwork here for when we talk about inflammation and fever. So we're going to come back to diapedesis in chapter 22. We'll talk about blood vessels allowing white blood cells to squeeze through. And we'll talk about chemotaxis. We'll talk about some of the leukocytes that are going to release chemicals when there's an infection. We'll see a little bit of that in this lecture as well. So let's look at the 5 types of leukocytes. This figure is a good visual representation of the granulocytes versus the A granulocytes. So A in front of something means not. These 3 have little vesicles filled with granules inside, and we'll talk about what's inside those. Sometimes it could be digestive enzymes, sometimes it could be a chemical. And then here we have A granulocytes. Some of these do have little vesicles with substances inside of them, but for the most part they're clear, right? So you can see this is a little bit more clear, opaque, white. It's not quite as granular as the granulocytes. So we're going to break down each one of these. Basically just putting into words what we just saw, granulocytes are going to be neutrophils, eosinophils, and basophils. Granulocytes are going to be lymphocytes and monocytes. They are going to have vesicles that are filled with substances. We're going to go through exactly what those substances are in just a second. The first type of granulocyte is a neutrophil. These are the most numerous, and you can see I have highlighted bacterial infection, right? So these are going to enter the tissue spaces. They're going to do cellular eating, if you remember phagocytosis, of pathogens. Remember, pathogen could be anything that causes disease. It could be bacteria, it could be a fungi, it could be a virus. But the majority of these neutrophils are going to target bacterial infections. Next up, we have eosinophils. Eosinophils are going to do phagocytosis of antibody and antigen complexes. So let's say you have a viral infection. It has an antigen, that's a surface tag, and we've created antibodies against that tag. We would call this an antigen-antibody complex. And so this can be the target for eosinophils. Allergens. You're also going to see higher eosinophil counts in people who have asthma, but the majority of eosinophils, or their main goal, is to basically eliminate any parasitic worm infections. The last one is a basophil. This basophil has granules with histamine and heparin. This is the classic allergy inflammation response, right? So you may have talked about mast cells in the skin in 201. Those release histamines. I'm sure we've taken antihistamines, right? So if your histamine, if the chemical being released from the granule of the basophil, if you have lots of histamine being released, it can stimulate inflammation, right? So you're going to feel stuffy and you have extra fluid, right? You're going to see blood vessels that are going to expand. You're going to see capillaries that are doing that diapedesis. Heparin is released during blood clotting. So basophils kind of have a little bit of a different function. It's more of an allergy inflammation. Sometimes it's good, sometimes it annoys us, right? So again, just a recap. 3 types of granulocytes: neutrophils, eosinophils, basophils, agranulocytes, lymphocytes, monocytes. We're going to talk about the agranulocytes right now. You do not have to know the percentage of each type of them. If you understand that neutrophils are the most abundant and that they're the main target for them is bacteria, that's fine. So the first agranulocyte is the monocyte. This one is usually in your tissue. And these transform into the large macrophage cells. So as soon as I see monocyte, I'm usually thinking macrophages. So anything that's really large that we need to engulf, do endocytosis or phagocytosis, we need to break it down and digest these pathogens, but also debris. So remember, macrophages can digest organelles that aren't working, anything that happens to be out in the tissue. It may not be a pathogen, it might just be cellular debris. Lymphocytes are going to be in the lymphoid organs. We do have lots in the blood. We're going to talk about the different types of lymphocytes when we talk about chapter 22, but for basic, we have T lymphocytes and B lymphocytes. T lymphocytes, it just says manage immune response. We're going to talk about cytotoxic T cells in the next chapter, and we're going to talk about helper T cells. So we'll learn a little bit more about that. B lymphocytes, their main contribution to your immune response is to produce antibodies. And then we have these cells called natural killer cells. They can attack abnormal and infected cell tissue. Natural killer cells and these cytotoxic T cells kind of do the same job. These words, leukopenia, hopefully by now we know leukopenia, means lower, right? Lower amount. So you have reduced leukocytes. This is going to increase your risk of infection. You have less white blood cells to fight off your infection. Leukocytosis is when you have an elevated leukocyte count. Could be a recent infection, could be stress, could be something worse, right? If you hear somebody's getting a differential count or a diff count, they're looking at each type of leukocyte and whether they're mature or immature, abnormally shaped, right? So you can have some issues if you have some leukemias, or you have some issue where in the process of making them, remember how we have to go through a multi-step process to have fully functioning leukocytes. Remember, we start at hemocytoblasts and kind of work our way through this cellular division and differentiation to get to these fully functioning cells. So sometimes you want to do a diff count to see exactly which ones are high and which ones are normal or not normal. And that leads me to this slide, leukemia. There's something wrong with your leukocyte forming cells. They're either abnormally developed or you have too many, there's a proliferation. And this is going to cause a decrease in erythrocytes and the megakaryocytes, which make the platelets. So you can have, basically, if the leukocytes are abnormal and outperforming, and you're making too many of them from your hemocytoblasts, there's not as many stem cells to make erythrocytes and megakaryocytes. So acute leukemia, you just have it right now. It's rapid progression, death typically within months, especially if it's a child. Chronic leukemia is a slower progression. It's lifelong. This usually starts to happen in middle age to older adults. Platelets, remember, are cell fragments. So when we talked about this as thrombocytes, we talked about that they're broken off, or they break off from megakaryocytes, right? And all of this is happening in the red marrow. Where did megakaryocytes come from? Hemocytoblasts, right? There are lots of them. So cubic millimeter, this is less than a drop of blood, right? This is 1 microliter. So teeny tiny amount if you don't know what that is. We do store platelets in the spleen along with red blood cells. It's kind of your storage tank, your extra in case there's some sort of trauma. So since these are cell fragments, they want to kind of point out that these are going to break down. They can be recycled, but you need to continually be making them. So we finally get to the topic of hemostasis, right? So stasis, stopping hemoblood. And these are the 3 steps that we saw in the very beginning. You're going to have a vascular spasm. You're going to see platelets aggregate to an area. So you're going to see this platelet plug formation. And then we have to do the coagulation phase. So the first step here, we're going to see vascular spasm. It is blood vessel constriction. This limits the amount of blood that can leak out. So that should make sense, right? We're going to constrict the area and stop blood from leaking out. The platelets and the endothelial cells, this is the internal lining of the blood vessel. Internal lining. Endothelial cells are the same thing as simple squamous epithelium, if you remember that. Remember how epithelium lines the inside of all hollow tubes? Well, they call the ones that line your blood vessels endothelial cells. So platelets and endothelial cells are going to release chemicals that stimulate this constriction. The greater damage you have to a blood vessel, the more constriction you're going to have. So greater vasoconstriction with greater vessel damage. The platelet plug formation, they want you to know that platelet activation should be inhibited normally. So if you don't have an injury, your platelets are just moving along, they're not sticking to anything, your blood vessel endothelial wall is smooth, it's coated with prostacyclines, these are going to inhibit platelet activation. So they stop platelets from sticking together. If the blood vessel is damaged, the collagen fibers in the vessel wall are going to attract platelets and allow the platelets to stick. There's also going to be some chemicals released. We'll talk about those in just a second. So as the platelets are aggregating, we're trying to block off this hole, right? Plug the hole, close off the injury. If you do not have enough platelets, that's going to impair hemostasis. Coagulation, we're talking about blood clotting. So this is where we're actually creating kind of this network of mesh. It's called fibrin. This protein comes from a precursor protein that we have to activate. So this is what I meant in the beginning where I said this is going to be a little bit more complex. There's several steps here that we have to talk about before we actually get coagulation. So vascular spasm happens pretty quickly, platelet plug happens pretty quickly. This coagulation phase is going to take a little bit longer. We've got more players, right? The end goal is to create this mesh where you're trapping the red blood cells, the white blood cells, the platelets, some of the plasma proteins, everything is coming together to kind of block this tear that we have in the blood vessel and also facilitate healing. These are the substances that are required for clotting. So you have to have platelets. You got to plug the hole first, and the platelets are going to release chemicals that bring more platelets to them. So you have to have the platelets. You have to have calcium. We're going to talk about clotting factors in just a second. And if you had me for 201, you know that I've talked about you need calcium for every muscle to fire or to contract, every nerve to fire, and for clotting. So I've said that repeatedly from the beginning especially when we talked about bone and we talked about things like parathyroid hormone, that if your calcium levels are low, you can steal it from your bone because calcium is critical. And so this is just another area where you can see calcium plays a major role. Clotting factors are made by the liver, so you have to be able to make those. And then vitamin K is an enzyme, or acts as a coenzyme. It's a vitamin, a nutrient, but it acts as a coenzyme that's required for the synthesis of clotting factors, and then specifically these numbers. You do not have to remember the clotting factor numbers. So I just want you to see if somebody's low on vitamin K, they can't absorb vitamin K, they're not going to be able to make enough clotting factors. If you don't have clotting factors, you're not going to be able to do the clotting phase. If you don't have calcium, you can't activate the clotting factors. And if you don't have platelets, you don't get to this coagulation phase. So now we're going to look at intrinsic versus extrinsic pathways. And they're telling you that they converge to form one common pathway. So we're going to see intrinsic pathway, we're going to see extrinsic pathway, and they're all going to converge to do or activate something called prothrombin activator. So they're saying both of these processes, both of these pathways lead to the same end result, the same common pathway. Here's the intrinsic pathway. If they're intrinsic, hopefully we're getting inside, right? So intrinsic pathway, there's some sort of damage to the inside of the vessel wall, and you can see that the platelets are going to stick, right? That was the platelet plug formation. That's before coagulation. And those platelets are going to activate these clotting factors. So where did these clotting factors come from? They're in your blood. They're made by your liver, right? And they're inactive. The platelets are going to activate, well, the damage is going to do vascular spasm, then the platelet plug, and that's going to activate these factors. And you can see it's saying that factor 12 here activates factor 11, and factor 11 activates factor 9. And calcium is required, and platelets are going to release this chemical. All of this comes down to where we finally get to the common pathway of prothrombin activator. Extrinsic pathway, outside damage. You can see tissue damage here. Tissue factor is going to be released. We need calcium in order to get to the prothrombin activator. You can also see calcium here. You can see factor 3 here. So more chemicals, calcium, factors made by the liver. We still come to the same end result. We are activating prothrombin activator. So two pathways, one if the damage is internal, one if the damage is external. But I do want you to see if this is outside damage, you've cut from the outside in, like the lady who's chopping here. This is about 15 seconds to get to this common pathway. If you go back to the other slide, it was a few minutes. So we finally get here. So they're showing you intrinsic and extrinsic. We all merge here on the prothrombin activator. I love the name. What does prothrombin activator do? It activates prothrombin into thrombin. And then thrombin is the activator to turn fibrinogen into fibrin. And fibrin is what actually makes the mesh. All of these fibers that are coming together to form this clot. So here are the 4 steps again. Prothrombin activator turns prothrombin into thrombin. I'm going to write prothrombin activator. Then thrombin is what turns fibrinogen into fibrin. And then we're going to have another factor, and we're going to start seeing the cross-linking. So basically creating this mesh network of fibrin. This is positive feedback. You are going to call platelets to the area. You're going to go through these pathways. You're going to activate prothrombin. You're going to create this mesh, and you're going to keep doing this until you plug the hole. until there's no more signals for this to keep going. You've finished your job, you've plugged the hole. So that's positive feedback, leading in all one direction until the job is done. The clot stops once the fibrin mesh starts to fill in. We can break down some of the fibrin, and we're going to talk about how we break down clots once they've served their job. If you remember before, I said that we're constantly making clots all the time. So this is, don't think of it as something really large, right? As a, I cut my leg and I have a gash. Yes, you're going to have clotting and you're going to see this process. But we also have micro tears on the inside all the time. So a lot of the capillary beds, I said there's places where only 1 or 2 red blood cells can get pushed through. So we do have internal teeny tiny micro tears in our blood vessels that have to have clots formed, and we repair the tissue. Then we have to get rid of the clot. So the point I'm trying to make is we are all constantly doing this clot creation. And if we just left the clots there, by the time we reached adulthood, we'd be filled with clots. So we have to retract the clot to squeeze the 2 sides of the blood vessel together to heal. We're going to squeeze out the serum. We're going to start breaking down the fibrin. We are constantly balancing clot formation and clot elimination. So any sort of imbalance, if you have too much of one, so let's say we're making clots all the time. We have increased clot formation and we have decreased clot elimination. We're going to have a lot of clots clogging up our blood vessels, right? So any sort of imbalance can lead to bleeding or clotting disorders, vessel damage, and think about blood flowing through your body. We can have inflammation. So just trying to make the point that once we create the clot and once the tissue is healed, we have to be able to break the clot down. On this clinical slide, we talk a little bit about hemophilia. They just want you to realize that this is due to not having a particular clotting factor. So you can see here results in the deficiency. You don't have to know which factor. They're just saying if you have hemophilia, you're missing a clotting factor or you're not making enough of it. And remember, females are XX and males are XY. So if the male has a deficient clotting factor gene, he's going to see that be expressed, right? He's going to have the disease. He's going to have hemophilia. Where if a female has only one of her chromosomes, if she's a carrier, one of them is normal, the other one, she's carrying the genetic disorder for one of those clotting factors. So if she's a carrier, she probably will not suffer from hemophilia, but males will. So that's why they say males exhibit the full-blown disease. You can also have thrombocytopenia. So hopefully we can look at that word now. We know thrombocyte, platelet, penial deficiency or low. And so basically if you're have some sort of bone marrow infection, you have cancer, if something's wrong with the development of your megakaryocyte, it could also be something all the way back to your hemocytoblast, right? They also want you to know that there are certain drugs that can cause excessive bleeding. They can interfere with the clotting process. That would be aspirin, ibuprofen, like NSAIDs, Coumadin, warfarin. So some people are prescribed drugs because they want their blood to move more smoothly, right? If they have a buildup, right, a plaque buildup inside their blood vessels, if their blood pressure is too high, we could want their blood to move a little bit more freely. But in some cases, if you're going into surgery, we're going to say, please, don't take any aspirin or ibuprofen or NSAIDs 2 weeks before surgery because we don't want to cause any excess bleeding. The opposite of not being able to clot enough or not having platelets being created to start the clotting process, you could have hypercoagulation. So this is increased clot formation in the blood vessels. You can see here that if you have increased clot formation, it can lead to something called a thrombus. And then if that dislodges and it moves around, so once it's moving, that's called an embolus. And you can see the term pulmonary embolism. So this is a clot that was in the blood vessel and it's now lodged in lung tissue. And that's a pulmonary embolism. Cause breathing problems, death, also cerebral embolism. So you had a blood clot that didn't get broken down. It's now traveling in the bloodstream. It's an embolism or embolus. If it gets to the brain and lodges in the brain, then that would be a cerebral embolism. So this can happen due to certain drugs that you take. So birth control pills can cause increased in clot formation due to things like vasoconstriction. So you have less movement of the blood. The platelets can just randomly stick to the inside of the blood vessels in some cases. Environmental, so prolonged inactivity, sitting in a plane, in a seated position for hours and hours. That's why they tell you get up, walk around, get your blood flowing. Basically, if you decrease your blood flow, there's more of a chance that the factors in your blood can start sticking together and cause unwanted clot formation. And then there are some genetic diseases where you might overexpress a clotting factor, right? So if you overexpress a factor, it could trigger unwanted blood clotting. Last, what happens as we get older, right? I feel like I depress you guys every single time. So older red marrow eventually turns to yellow marrow. So we have less ability to do hematopoiesis, and that's all, right? That's making erythrocytes, leukocytes, platelets, thrombocytes, right? You can become anemic, you can produce fewer white blood cells. It could also have something to do with your clotting ability if you're not making enough platelets, right? So kind of over time, everything stops kind of working as well. All right, I'll talk to you guys next time. Bye.